Hi, good morning and welcome. Thank you for inviting me to speak today on inhalation injuries and irritants and the introduction to management of chemical agents for the Mountain and Plains Regional Disaster Health Response System. It's a pleasure to be with you. This program is funded by ASPR, and my presentation does not represent the official policies of the U.S. government, and this is not a substitute for professional medical advice that you should seek. I have no conflicts of interest to discuss. In discussing inhalation injury, it's important to think about determinants of toxicity and some basic toxicology principles. In determining the exposure and dose, we oftentimes do not know this, particularly in emergencies, and we think about concentration of the gas in the air times the minute ventilation of the person. And this is based on Haber's law, which is the dose is equal to the concentration times time or duration. And that gives you essentially a mass of molecules that might be entering the lung that are available to interact with tissues to cause a problem. Of course, we're always concerned about the health of the individual, their susceptibility, as we refer to it in toxicology, and how that interfaces with the physical chemistry of the specific agent we're talking about. Most notably, the water solubility, the pH of the substance, the vapor density and volatility, and mixtures, particle size, et cetera. These are all important components to consider. Irritant gases in general, the onset may vary depending on the solubility of the gas. I think you can appreciate how an acute chlorine exposure can be very irritating very quickly to the eyes, ears, nose, and throat and cause coughing, whereas a very water-insoluble compound such as ozone or phosgene can penetrate deep into the lungs before it causes any irritant effects that develop a bit more slowly. And these are known as the warning properties or early warning properties of certain gases. While they all may be irritating, the onset of the irritation is more delayed in lipid-soluble compounds. Of course, acids and alkalis may become part of a mist, and they can burn just due to physical pH changes. Other chemicals may cause free radical generation, such as phosgene, and cause typical fibrosis ultimately in the lungs. And the importance of water solubility can't be overemphasized because that really determines some of the site of pulmonary injury, and we'll discuss that in a bit more detail. First, I want you to appreciate the respiratory tree and the tissues that line the respiratory tract. The normal surface area of the upper airway is like 2 sheets of paper, where the lower airway portions of the alveoli, of course, is about the size of a tennis court. And that gives you a good idea of the area that can be impacted. And we see the different types of glands, and their depth in this chart shows how deep these glands, cartilage, smooth muscle, and elastic fibers go into the lungs. And you can see why these are important tissues in asthma, and you can see how they're deep in the airway. So if we think about the physical chemistry and pulmonary tox, we think a lot, and you'll read a lot about high water solubility and low water solubility or fat solubility. And as I mentioned, the onset of symptoms is very rapid in highly water-soluble compounds such as chlorine or acids, whereas with low water solubility, these symptoms may be delayed, such as ozone or phosgene. So warning properties are very good with high water solubility compounds like chlorine, and low warning properties or poor warning properties with low water solubility. With highly water soluble compounds, they tend to impact the upper airway, where there's lots of moisture in the upper airway and it burns upon contact, and it's much lower in lower lung injury compounds with low solubilities. So we know that toxins exert both local effects, and they may be irritant and ultimately either transient or pulmonary, or they may contribute to systemic toxicity if they're absorbed through the alveoli into the capillary network. So it's easy to reach the systemic circulation because of very large pulmonary capillary circulation surface area. and it's only slightly slower than an intravenous injection. And I think we all can appreciate that in this day and age with fentanyl inhalation, which is very quick to react, almost as rapid as an intravenous injection. So inhalation, of course, is the primary route of industrial or accidental exposures, either in the workplace or an accident site. And the pulmonary system, you need to think about this as a target organ of toxicity, as well as a portal of entry into the systemic circulation for other substances that may get into the body. Here's a little bit more detail of the physical chemistry and expected clinical effects of several different irritant gases like methyl isocyanate, ammonia, chlorine, phosgene, and hydrofluoric acid. We see the water solubilities, high, intermediate, low. In this column, they're odor warning properties, which are not dependent on solubility, but in fact more dependent on the specific chemical itself. Vapor density refers to how heavy the gas is. The higher the vapor density, the more likely it is to settle out. The lighter the vapor density, the more likely it is to evaporate. And water is about 1, so water vapor is around 1. So we see that, for example, phosgene is very heavy and more likely to settle out, as opposed to ammonia, which is more likely to volatilize and disperse in the air column. Expected chemical effects, we see that since it's high water solubility, obviously methyl isocyanate is very injurious and causes early morning symptoms without systemic effects. However, if we look at hydrofluoric acid, a compound with also high water solubility, low vapor density, causes both upper and potentially lower airway injury, and it can cause significant electrolyte and cardiac rhythm disturbances because of hypocalcemia. So that's an example of the systemic effects that might occur from inhaling a gas. Irritant gases, if we think about highly water-soluble gases like chlorine, they dissolve in water in the upper airways, as I've mentioned. So this becomes very irritating to the eyes, ear, nose, and throat. And that limits the dose to the lower airway. So there tends to be upper airway deposition and a lot of victim intolerance where they really can't tolerate this irritant effect. We also have to be concerned about burns to the skin of the face and neck as well with these type of irritant exposures, and it's something to consider. And I'll emphasize at the end of the slides as well is that don't forget about the eyes. This is a common thing that is missed with irritant exposures, particularly with highly water-soluble compounds. They'll burn the eyes, and that's very important to remember. If we think about particle size, and this might be a water droplet particle or an actual physical hard particle. Very large particles tend to be filtered out in the upper airway, and smaller particles tend to proceed all the way to the alveoli, and ultimately the smallest get phagocytosed by alveolar macrophages in the lungs. And this is important when we think about, for example, an N95 mask, which filters out 95% of particles greater than 2.5 microns in diameter. So N95 masks filter out things just before they reach the alveoli and the bronchioles. There's several different ways that a particle can impact in the lung, and that depends a little bit on the type of chemical, whether we're talking about interception of the particle on the wall just because it can't make a turn as well and bangs into the wall. There's an electrostatic charge on the particle. For example, a particle of freshly fractured quartz silica can actually have a charge on the surface, and the surface charge can affect its deposition in the lungs. Gravitational sediment is heavy particles that tend to just drop out of the airway, whereas Brownian diffusion is really very light particles. They just float in the air column and ultimately can find their way deep into the lung. Alveolar cell types are important to review in this context. We think of type 1 alveolar epithelial cells. They're responsible for about 90% of the total alveolar surface area within the lungs and are essentially the air exchange cells of the lung. These are chief structural cells of the alveolar wall to maintain gas-blood barrier and gas exchange. So these are the working cells for gas exchange in the lungs. They're fragile, they inflame when exposed to inhaled toxins. It's obviously very thin, a couple of cell layers thick between the air sac and the blood. And so they're very impacted by irritant gases. For type 2 alveolar cells are really more cuboidal cells that we see. They produce surfactant, and that reduces the surface tension to keep the alveoli sacs open, and these are important cells. There's lots of phospholipids that are found in the type 2 alveolar cells, and their job is really to stabilize the alveoli, to increase lung compliance or flexibility, and it eases the work of breathing to have the fatty acids from the surfactant in them. So I mentioned the 5 types of particle deposition, where we have airway bifurcations. We have gravitational in the long airway segments where it settles out, Brownian diffusion of small particles, and the electrostatic deposition from mechanical dispersion of a substance, and interception, which typically applies mostly to fibers, and that's something we're not covering in this lecture. So air breathing can cause a lot of turbulence in the airway, and this is really important to think about. Slow, deep respirations enhance sediment deposition, spreads particles more uniformly in the respiratory tract, where shallow breathing increases impaction in larger airways in the central part of the chest. Aerodynamic diameter of a substance is really impacts the inertial and gravitational motion of particles in the air. And these are particularly particles that are greater than 10 microns, and they deposit in the upper airway. They just don't flow well in the airway. Smaller particles can deposit in lower airways, and obviously the farther down you go, they can reach into the lung parenchyma. Particles less than 0.1 micron largely remain in the airstream, and these are referred to sometimes as respirable particles, in that they can go in and out of the airway as you breathe. And again, these particles may be liquids in the form of a gas particle, or they can be solid particles. And of course, particle size, if we're thinking about fibers, it's really important to think about length to width ratio, which doesn't impact this. Oftentimes in emergent situations, such as explosions or disaster type settings, you're going to have both dust particulate and contaminants, including fibers, as well as gas exposures. And so these should be considered all in the same time. So I mentioned the aerodynamic diameter and where they're deposited, but I wanted to show you an example of an airway. And this is a chest x-ray on the left showing significant multifocal infiltrates, and on a CT scan showing the very significant dense evidence of alveolar hemorrhage and some bronchiolitis as well. So how do we manage these cases? Well, the most important thing is to remove people from exposure in a safe manner. So the rescuers must be safe when they enter into this environment. If the patient has eye irritation, it's important to irrigate the eyes or skin if it's involved. Usually extensive decontamination is not necessary unless it's a liquid exposure, but gas, vapor, or that type of exposure typically doesn't need as extensive a decontamination. Delaying decontamination can impede the care and have other negative effects. Oxygen, of course, is always important. Beta agonist for those patients who may be wheezing to cause some bronchodilation may be very helpful. And airway management, both early and late, depending on the nature of the substance and how rapidly progressive this patient is. In toxicology cases, we think about airways failure as being quite a dynamic process, where you might have a little irritation to begin with, followed by much more difficulty breathing, and then point you might even have stridor and a critical airway that you have to deal with. So it's a very dynamic process requiring close monitoring. So I think some pearls to ponder here, of course, is to number one, protect yourself. Protect your eyes, protect your skin, your hands, and your respiratory tract as best you can. Chemical injuries are dynamic. As I mentioned, they are evolving injuries. These may happen very quickly, or they may be more slow to evolve, like substances that are not very water soluble, like phosgene or ozone. If we have a chlorine gas exposure, and chlorine and ammonia are two of the most common things that are water soluble, there's some data suggesting sodium bicarbonate nebulizers may actually help limit some of the injury, at least on the pH side of things. Again, don't forget the eyes. Here's an example of an ammonia inhalation injury that caused corneal opacification on a patient. So make sure you irrigate their eyes if it's a highly water-soluble compound. Upper and lower airway injuries, control the airway early and often. It's always easier to take the tube out later than to get it in a critical moment. Supplemental oxygen, humidification sometimes helps that as well. And ventilator problems, always think about early edema and late fibrosis. These patients have lots of fluid in the airways, and in late stages, fibroblasts invade the lung and cause scarring and may actually increase the resistance to breathing, and you'll see increase in plateau pressures on ventilators. And these patients early on with edema seem to benefit from some positive pressure ventilation. So some key learning points I'd like you to remember is the toxicity of a gas is determined by the dose, which is the concentration times time times the respiratory rate. Or another way to think about it is just the concentration times the minute ventilation of the patient. We need to think about the inherent toxicity of the substance. There's obviously a big difference between inhaling water vapor and inhaling hydrochloric acid vapors. Water solubility is important because it tells you where the injury may occur in the individual and what you might need to decontaminate. But you can't rely too heavily on water solubility. For example, we know that if we're calculating our dose based on concentration times minute ventilation, you can imagine a firefighter going into a cloud and losing their supplied air respirator, where they are working very hard, pulling hoses in full turnout gear with a mask on. If they lose that mask and are inhaling, their minute ventilation is much greater than someone at rest. And so water solubility can be overcome if your minute ventilation is very high. Warning properties are important to note, both when they occur and when they may not occur. And if you're around areas or working in areas of certain gases that don't have good warning properties, it's important to have those posted. And oftentimes monitors are placed in those kind of environments so there can be an audible alarm if there's some exposure. We always worry about large gas volume releases and the impact this might have on not only rescuers, but the community surrounding that. And most regulations we think about regarding toxic gases tend to be unintentional releases or accidental releases, be that a tank car, railroad car, or a fixed setting where the gas is released. And with that, I want to thank you very much for your time with us today and look forward to perhaps giving further talks in the future. Thank you very much.